down his legs. So it's really about thinking about what could be going on here. And obviously this is an oncology talk about oncology emergencies. So I'm hoping that you all are second guessing already what's going to be going on. Next slide. Thank you. Oh, there we go. So in terms of assessing him, so obviously you'd anticipate he'd have had an examination, and from an investigation point of view, here are his bloods. So he's mildly anemic. He has a raised PSA, so he's had radiotherapy. His PSA should be 2 or less. He's got a raised alkaline phosphatase and an okay calcium at the sort of top end of what you might expect. So in a man with previous prostate cancer who's got a raised PSA and back pain, we're going to get an MRI scan. So that's what's coming up next slide. So could you all in the chat, would you mind just putting what type of MRI this is? Is this T2 or T1 sequence? So 10 seconds to tell me what you think, T1 or T2? Oh, I can't see anybody putting anything in the chat. Oh, someone's braved it. So we've got one for T1. Jonathan, anyone else want to hazard a guess? Leisha's T2ing. Can either of you say why you've chosen what you've chosen? Or if anyone else knows what might help you? Feel free.
Sorry, mine was just a bit of a random guess. I just wanted to put something down. Sorry.
Oh, thank you. I appreciate it. Thank you. So, so CSF is bright on a T2 sequence. So, so whenever anyone says what is this for MRI, if you look at the CSF and you immediately see bright stuff around CSF, you know you're in T2. So for this gentleman, does my mouse pointer, no, because you're projecting, aren't you, Anita? So if you have a look, you can see from the bottom, you can see his sacrum and then L5. And then above that, there's a vertebrate that's very abnormal and has bulging out towards the, that'll be quadra equina at that level at L4. And then L3 has got a dark area of hypodensity. And then you've got a normal looking vertebrate and then another one. So he's got 2 levels of core compression. I'd need to show you the axials to confirm that. And then 1 level of possible core compression, perhaps impending. Sorry, I should say 1 level of core compression and then a quadra equina because the spinal cord's finishing around L1. Next slide, please, Nita. So we have got a pathway for spinal cord compression. For patients who have signs or symptoms of neurological signs or symptoms, they need an MRI within 24 hours. And I wouldn't really be expecting you guys to necessarily be requesting MRIs in anything less than that. For some of our known, so this is a pathway for known cancer patients, I should say. So already got a diagnosis of a known malignancy. There are a group of patients who we know have cancer and they might have back pain, but with no neurological symptoms. And for those, we quite often will get an MRI, but sort of do it within the 7-day turnaround. But that's probably something more for oncology to do rather than expecting you guys to do that. The patient obviously needs to be assessed and full history and examination. And if their MRI needs to be reported urgently. So for someone who's having an MRI the same day for query core compression, which they should have within 24 hours, you should expect the report to be available within an hour. And radiology know that, but sometimes it does need a little bit of chasing up. If they've had a non-urgent MRI, often we do find that if they have got core compression, it gets flagged to us quite quickly. So if you've got someone with core compression, you need to liaise with the spinal cord compression coordinator, who's the oncology registrar on call at Brighton via switch, and also do refer a patient to neurosurgeons. Provided you know what their cancer is, you can start dexamethasone, and it would standardly be 8 milligrams BD morning and lunchtime. And then where the oncology registrar or the timing of the oncology registrar giving advice and the neurosurgeons will depend a bit on the scenario, and we'll come back to that in a few slides' time. So once someone's decided whether they're for surgery or radiotherapy, then if they're for radiotherapy, they'll either have to go to Brighton, or it's possible they might be able to have it here in Eastbourne. And if it's for surgery, they get transferred over to Brighton. And if they're having radiotherapy, they just go for the treatment and they come back, so they still stay in their bed. Next slide, please, Anita. Thank you. So just a few other reminders. You want to get the urgent MRI, and it needs to be whole spine. And the reason for that is that they may have other areas of core compression or impending compression higher up that you'll miss if you only do a limited spine MRI. We talked about the DEX, and the importance is that it's not after lunchtime unless it's the stat first presenting dose. So if you see them and clock them in at 3 o'clock in the afternoon and you're worried about core compression, they can have a stat dose of DEX, but their regular DEX shouldn't be in the afternoon because it will stop them sleeping. They need to have it with food ideally, so it's written up at lunchtimes, and a PPI while they're on high dose DEX. And things that can be easily overlooked are ensuring someone's got sufficient analgesia, thinking about catheterization if they're in retention or incontinent, and also really important to think about laxatives. And probably important to have those on the PRN even if the patient doesn't need them, in case things change. Okay, next slide. So why is this an emergency for oncology? So it can affect up to 1 in 10 patients, metastatic core compression, and probably more common to see it in prostate cancer, which I treat. The reason it's really important to be aware of core compression and to pick it up early is that 80% of patients that are able to walk at diagnosis will retain that ability to walk after treatment for core compression. But of those unable to walk at diagnosis, only 10% will regain the ability to walk. So once they've developed neurological signs, pretty much you've missed the boat, and we really want to be diagnosing this early. Next slide, please. So I mentioned about radiotherapy versus neurosurgery, and I thought it'd just be helpful to talk through the thought processes that might be going on when you're trying to decide what might favour surgery and what might favour radiotherapy. I don't know if any of you have had to refer a patient, but it's quite laborious, and there's often multiple conversations back and forth with neurosurgery asking for the same information twice. And there is some reason for that. I'm trying to be generous. Anyway, the reasons you might consider neurosurgery is if this is the first presentation of cancer and it's the only site of disease. So if they're not known to have cancer and there's no other sites of disease, you might err towards neurosurgery. Equally, if you know they've got a radio-resistant tumour, so for example, kidney cancer is quite relatively radio-resistant, you might be more inclined to do surgery compared to something that's highly chemo or radiosensitive, for example, a lymphoma or a small cell lung cancer. If they've got spinal instability, which often the neurosurgeons will not be able to judge and might need a CT, but you're probably more worried, particularly worried if it's in the neck, then surgery is going to help with that instability, whereas radiotherapy isn't really going to do anything for that. And there's often a bit of a sweet spot in terms of the risk benefit of neurosurgery. So generally, the surgeons will often shy away or not want to risk surgery if the patient has no neurology at all, because the risk is that they'll make their neurology worse. But equally, if they've got too long established and significant neurology, so if they're already paraplegic, then they're not likely to benefit. Things that might make you favour radiotherapy, and some of these are positive reasons to do radiotherapy, and some of them are active reasons not to do surgery. So patients that have a poor prognosis are probably not going to survive long enough to benefit from neurosurgery, and bear in mind it's not just the risk of surgery, but also the rehab time afterwards. If they've got multiple levels of core compression or lots of heavy bone infiltration where there's going to be really difficult to have anything to put the metalwork into, that's going to put people away from neurosurgery as an option. We've talked about having a highly chemo or radiosensitive tumour. The neurosurgeons really want to know, they're really interested in what is their extraspinal disease doing. Have they got a really heavy burden of extraspinal disease? And they'll often ask for an up-to-date CT. If they've got loads of disease outside the spine and their prognosis is relatively poor, you're not going to put them forward for neurosurgery. And equally, if they've got no or few systemic treatment options, you don't really want to be putting them through a major operation to their spine if they're going to die rapidly from metastases to the liver. Clearly, comorbidities and frailty are a major part in deciding if neurosurgery is appropriate, and also patient preference. So I just thought it might be nice for you to see a bit of what we do in radiotherapy. Next slide, please, Anita. So for radiotherapy planning, patients will get a CT scan and it's a standard CT scanner, more or less. It's a slightly wider bore than a diagnostic scanner. And the bed, although there's a pillow on that bed, and I don't know why, because there shouldn't be, but the bed is hard. That sort of thing that looks like a pyramid wedge by the scanner is a cushion that goes under the knees. So they have a CT scan, and then most patients will have a tattoo, which is what that little bottom right picture shows you, someone's skin with a little black dot of ink, which is a tattoo, and that helps us line them up for their treatment. Next slide, please. So we take the CT scan, and for palliative radiotherapy, we then plan. It's a fairly basic form of radiotherapy planning. So essentially, we want to decide where the top and bottom and left and right of the radiotherapy field is going to sit. If you think about the radiotherapy as a beam of torchlight, and on this image, the yellow lines on the sides are the edges of that beam of torchlight, and it's coming from the back going to the front. So the radiotherapy, like a beam of torchlight, is divergent, so it's wider the longer it goes. And you're going to decide where you want to treat in terms of which vertebrae you're going to treat. So for this man, he's got at the bottom, the field is going down to what looks like at the bottom of S1. And at the top, if you count it up, you've got L5, 4, 3, 2, 1 to the top of L1. And we normally treat one vertebra above and one vertebra below the area of core compression. For this man, he's got two areas, so he's got a wider field. And we'll do the next slide, please, Anita. And then you also need to think, so that's telling you where the previous slide was telling you where the top and the bottom of the radiotherapy was going to be. And this is telling you about how wide it's going to be. And what you want to do is cover the whole of the vertebral body and ideally also cover the transverse processes. And you can see the exit beam coming through the patient is including quite a lot of bowel loops. So when we're planning radiotherapy, not only are we making sure they've had dexamethasone and a PPI, but we're also thinking about the potential toxicity. So for patients with lots of bowel in the way, they might get diarrhea, so we're thinking about Imodium, but also they might get nausea from small bowel irradiation. So ondansetron is quite helpful to give prophylactically about an hour or half an hour before radiotherapy to prevent both of those things. So on the next slide, you can see reconstructed, so it's a digitally reconstructed image. It looks like a traditional X-ray, plain X-ray, which just gives you an idea about where that radiotherapy field is sitting. Okay, next slide. So we have a radiotherapy unit here in Eastbourne. It's down by the helipad near endoscopy, and it opened about 3 years ago. So right at the far end of the corridor, there's a patient waiting area, and then they come down this corridor. Next slide. And then these are the changing rooms. So some patients will need to change because we don't want any bits of metal over their skin for the radiotherapy. And then they go through those doors. Next slide, please, Anita. Anita, can we have the next slide? Thank you. So through those doors and out the other side, they come to we've got two machines, two radiotherapy machines. So they come out the other side, and you can just about catch the radiographer sitting in their room on the right, and there's a mirror image on the left side. So they walk down towards the machine, past the radiographers. Next slide. They're the radiographers planning the treatment, delivering radiotherapy. And next slide, they'll then go and have their treatment on the radiotherapy machine. So as you can see, the patients will lie on that hard black couch, and the machine will move around them to direct the radiotherapy beam. So it's really important that patients have good analgesia before they come to radiotherapy, because the couch is hard deliberately. And it's also important that they're not agitated or confused, because they will be high off the ground with no cot sides or restraints and on their own. So I think that's the last slide about core compression. If anyone does want to ask any questions, please feel free to put it in the chat. But otherwise, I'll keep going, and we'll talk next about neutropenic sepsis. So next slide. So this, I'm hoping that you guys will already have come across neutropenic sepsis or as part of your clerking, and that this is relatively straightforward and familiar to you. But please do flag up if there's anything that I've covered too quickly. So this gentleman's Peter, and he's a 64-year-old man with small cell lung cancer, and he had chemotherapy, palliative chemotherapy, 9 days ago. Just pretend we don't have COVID. He had a cough and malaise. And then you're thinking, well, what else do I need to know, and what are you going to do next? So you're going to examine him. You're going to do your standard bloods and arrange a chest X-ray. Next slide, please, Anita. Your main worry about patients on chemotherapy that present unwell is neutropenic sepsis. So anyone that's unwell or has potential sign of infections, we need to treat them with high-dose broad-spectrum antibiotics immediately. We don't wait for the blood test result. So they'll have their bloods, hopefully had some blood cultures sent, and then within an hour of presenting to A&E, they have their first dose of antibiotics. And then the bloods will come through, and then you can decide what needs to go on from there. If they've got a central line, it's really important that they have cultures taken both from the central line and peripherally. If they're hemodynamically compromised, they might need a blood gas. And it's important to look and see if there's any focal source of infection, so a central line or a wound. Have they got any diarrhea, sputum? Could it be urine? And there often isn't a focal point, but it is important to look for. And we've talked about chest X-ray. Next slide, please. So we've also got a pathway for neutropenic sepsis. Sorry, I should have mentioned these are all available on the intranet via Acute Oncology, and I've put a little link to Acute Oncology at the end of the presentation. But this is just reiterating. I'm sorry if it's too small to see on here. This is on the website. So it's thinking, could they be neutropenic? Do they have any evidence of infection? Immediately take bloods and do antibiotics. I think one of the things, next slide, please. Some things that are important to remember about febrile neutropenia is not everybody has a temperature. They could still be neutropenic. Any drugs they take, such as paracetamol or even potentially steroids, might mask a fever. And the other thing to consider is if your patient you're seeing is hemodynamically compromised, having a consideration about how much you're going to escalate care. So antibiotics, IV fluids is going to be your ward-based level ceiling of care, but some patients may be appropriate to consider HDU or even ITU setting. And that will depend on what their prognosis is from their cancer, what their comorbidities are, what future treatment there is. But and that's something worth considering, and actually really important to have a conversation about, particularly in the people you're really worried about, so that that decision and discussion can be made with the right people, i.e. the right people from ITU, HDU, but also the patient and their family, when everyone is around, not in the middle of the night when the patients suddenly become really unwell. You need to take into account as well, a lot of patients are not for resuscitation and may have already made that decision in the community. And that doesn't necessarily mean that they shouldn't be for full sort of escalation of ward-based care and proactively treated. So that is a really short section on neutropenic sepsis, which isn't designed to diminish the importance of it. And it's really important to remember that this can happen and that patients can get really unwell really quickly. But I think it's a relatively straightforward part of oncology emergencies. Please do feel free to ask anything if you'd like me to expand on it. But while we're thinking about that, we'll talk about immunotherapy, because there's quite a lot about immunotherapy that I think it'd be worth covering. So immunotherapy is a different way of delivering cancer treatment, and lots of people are quite familiar with chemotherapy and radiotherapy, and not so much with immunotherapy. It's been around for quite a number of years now in melanoma, and has slowly crept into lots of other cancer sites. Well, not slowly, but has come into lots of other cancer sites. So the way immunotherapy works is by acting on some checkpoints that exist between the T cell and antigen presenting cells, or the T cell and cancer cells. So naturally cells produce proteins, antigens, and they show them at their cell surface. And T cells can detect proteins that shouldn't be there, so from viruses or bacteria or cancer cells. But there's a natural mechanism that the body has to prevent the T cells becoming overstimulated, and they're called checkpoint inhibitors. So they switch off the T cell. And what cancer cells do is they exploit this checkpoint inhibitor interaction, and they stop the T cell then becoming activated and then activating the rest of the immune system. So when we use immunotherapy, what we're doing is we're releasing that brake that is artificially being put on by the cancer cells, and essentially allows the T cell to see the cancer cells and then employ the immune system to attack it, I suppose. So on this diagram, you can see a T cell, and it's showing multiple different receptors, because there are lots of different types of immunotherapy that work on different parts of that checkpoint interaction. So a very common interaction is between PD-1 and PD-L1, and you can see at the bottom of the screen, drugs that block PD-1 are nivolumab, pembrolizumab, and then you've got drugs that block the other end of that interaction, PD-L1 inhibitors, and they're all resulting in releasing that brake and allowing the immune system to recognize cancer. So not only have we got multiple different drugs for immunotherapy, we've also got lots of different cancers that we can use this for. Have you seen that I've just changed the slide? Can I just double check that it's now changed?
Yes.
Great. So this is just an example of one combination of immunotherapy called nivolumab and ipilimumab, and it's really shown, I've shown it to you just to show that it's used in a broad range of cancers. So this is a case study of a lady who has metastatic melanoma, and presented and had two cycles, I should say, of combination immunotherapy. So the drugs that we were just talking about, nivolumab and ipilimumab. 5 days after treatment, I thought it was a lady, but it says he here, doesn't it? He developed a rash all over his body. So you can see the photograph, hopefully. So it's a widespread, generalized rash, sparing the face and mucosa, with no blistering or bully. So the question is, what would you do? What do you suggest? So before we get on to management, I just wanted to show you how immunotherapy toxicity can affect essentially any bit of the body. So immunotherapy has been used in lots of different cancer sites, and for some cancers like melanoma, it's completely revolutionized treatment. And for a minority, but significant minority of patients, it can result in long-term control. So that means metastatic disease that responds completely to treatment, and for which patients may have no evidence of active cancer going on for years. So essentially cure. The but about immunotherapy is that you can have immune-mediated side effects, and they can happen anywhere in the body. So an itis of any organ you could care to mention can be affected by these, although some is more common than others. So when we're thinking about toxicity, either from chemotherapy or any cancer treatment, radiotherapy or immunotherapy, we're thinking about grading it. And so the definition of the grade of the toxicity will depend on the underlying toxicity you're describing. But in general, 1 is a mild toxicity and grade 5 is death. 4 is life-threatening and definitely needing hospitalization. And so it's really important to grade it because the treatment will depend on the grade. So for example, for skin reactions like this patient had, for grade 1, we're not too worried, probably some emollients. For grade 3, you withhold treatment and treat with corticosteroids, whereas for grade 4, you permanently discontinue treatment. So the management of this is high dose steroids, and it's 1 to 2 milligrams per kilogram of oral prednisolone initially. So the general principles of managing immune-related toxicity, it's really, really important that patients understand that they can get side effects and what they might be. On the slide that we talked about here about potential toxicity, you can see that there are quite a few endocrine toxicities, including hypophysitis and thyroid dysfunction. And hypophysitis can present really non-specifically, and patients might just generally feel unwell. So it's really important that both the nurses that are advising patients on the patient line, but also patients and their carers understand that we need to have a really low threshold of suspicion for any symptom being attributable to immunotherapy. And it's not like classical chemotherapy. So educating patients and our staff is really important. We might need to rule out any other infections or any other etiology that's happening. And certainly we'd normally be withholding the drug. And for example, if you're giving a combination of 2 different immunotherapies, you withhold both of them. If they're having a grade 2 or above toxicity, you might want to consider consulting a specialist. So for example, an endocrinologist, or for this patient, a dermatologist. And the treatment for pretty much every toxicity, barring hormonal endocrinopathies, is steroids. And they get tapered gradually over a period of several months. So for this patient that had the rash, this is a photograph of the same patient 2 days after starting steroids. So because they had such a florid rash affecting so much of their body and required admission and had high-grade disease and high-grade toxicity, they went straight onto IV methylprednisolone. So for some patients with lower grade disease, they'll start on oral prednisolone, and then if they don't respond after 48, 72 hours, then you'd admit for IV methylprednisolone. But for those with higher grade toxicity, you might go straight to IV methylprednisolone. Patients taking Piriton and is comfortable and feels well in themselves. So they've had a dermatology review, and then they're going to switch to the oral prednisolone, which again would be, so this is 80 milligrams, so it's usually 1 milligram per kilogram, can be 2. And it gives you an idea that you're going to be dosing, gradually reducing that dose. And for some patients, they really are on steroids for quite a long time. I think this slide is a really useful slide because it gives you an idea about the frequency with which different toxicities happen. So if you look at the black boxes, it gives you an idea about the number of patients. Again, this is an example for nivolumab and ipilimumab, but skin reactions happened in half of patients, endocrinopathies in a third, colitis in just under a third. So this is patients with toxicity. What is the spread of toxicity? So skin is common, as is endocrinopathy, and colitis is relatively common. If you look at the image on the right with the blue bars going across, this gives you an idea about the time of onset of symptoms. So the really big difference with immunotherapy compared to, say, chemotherapy is that the onset is less predictable. So although the median time of onset in the little sort of funny lozenge shapes is usually 1 or 2 months after starting treatment, actually, if you look at the range of onset, it can range from anywhere to within a few weeks of starting treatment to over 2 years later. So it's really important that patients are aware of this, and also it can actually start even if patients have finished treatment. So if patients have to stop treatment, for example, if they had a colitis and they stop treatment, actually they could still develop one of the other toxicities, even having completed their treatment several months or even many months earlier. If we look at how the median time to resolution of toxicity, again, you can see that most people, for most toxicities, they're resolving pretty quickly, so perhaps within a couple of months. But again, that range is quite wide. The endocrinopathies are different. So for nearly all immunotherapy toxicity, the answer is steroids. So if in doubt, steroids. For the endocrinopathies, it's replacing the hormone that they can't make. And cortisol is really important, and that's the one that's really easy to miss because patients often feel just non-specifically unwell. So the final slides is just really to let you know what's out there for support if you do have any oncology emergencies or any questions related to oncology. So we've got an acute oncology service at both Conquest and Eastbourne that is nurse-led and supported by consultants. It's a Monday to Friday 9 till 5 service. And the acute oncology team are there to help with any patients that are admitted with symptoms related to their cancer or related to their cancer treatment, or for patients who might have a suspected new cancer. And we'll aim to assess the patients within 24 working hours. And there's a referral form via the intranet on eSearcher. And just on the right, just to show you a quick screenshot, we do have an acute oncology service page on the intranet, and it does have links to those flowcharts for core compression and neutropenic sepsis management, but also it's got links to guidelines, which are called UCON's guidelines, and they will tell you how to manage pretty much any acute oncology toxicity. If you have any emergencies out of hours, there's an oncology registrar on call at Brighton via switchboard, and they are used to taking queries from across the patch. If you needed out of hours advice on the side effects of cancer treatment, you can contact Pevensey Ward because they'll have a phone. So for example, at this end at EDGH, it'd be Pevensey, and they have a nurse that's advising patients, but by all means call the registrar if in doubt. So thank you for dialing in to another Teams meeting. Some of my slides have got acknowledgement to the acute oncology team at Brighton, Ali Hodge, for her immunotherapy slides. I'm really happy for anyone to get in touch and email me if you have any questions, or if you'd like to come and do some oncology and do some oncology taster days. We're really happy to invite people to come along and see what we do. Hopefully Anita will send you a feedback form, and that's really important for me because I do these talks and your colleagues will have to sit through my talk, and it'd be great if there's anything you think would be useful to have to add it or to edit it, and I sort of change and update the talk each time. So if there's anything anyone wants to ask, please do it now. I think you've got your next talk at 3 o'clock. Is that right, Anita?
Yes, that's right, Dr. Adderolper.
I'm guessing I'm hoping you're all still there.
Yep, I think they're still there.
So I'll hang around for another couple of minutes, just in case anyone wants to put their hand up and ask anything. But thank you for dialing in and taking your time out.
Thank you very much.
Thanks, Anita.
Thank you. As I say, next speaker will be at 3 or shortly before. So if you're going to take a break, if you could come back, thank you.